Good evening, friends. Good evening, friends. So welcome back to Weekend with a Maestro program. That is 10th episode of Weekend with a Maestro program. Today morning, we had a wonderful program. That was the Journal Club. We had a fantastic beginning for that, our new event. That was a stupendous success. So thank you very much to whoever joined for that program as well. And welcome back to another exciting program. That's the 10th episode of Weekend with the Maestro. And today we have an interesting topic, that is rhinoplasty for crooked nose deformity. Okay. And some meeting etiquette we have to pass, we have to observe. That is, please mute your audio so that there is no disturbance for the program. We can have a fantastic program today as well. And if you have a query, you can stop us at any time. Please raise your hand if you want to ask a question, any question. Okay, you can stop us at any time. No issue at all. Okay, uh, you can ask us, stop us anytime. And friends, you can always use the chat box also for asking questions. Okay, and of course, in the end, we'll have a final discussion also. Okay, we can you can ask questions that time as well. Okay, anytime you feel you need to clarify some point, just raise your hand. That's all. Okay, friends. So with this, we have no financial or personal conflict of interest as far as this event concerned. This event is sponsored by Basaveshwara Medical College and Hospital, Karnataka ENT Hospital and Research Center, and Champions Education and Medical Society, Chittadurga. Okay, and our future programs, Weekend with the Maestro, the episode 11 will be held on the 20th March, the next Sunday, from 6 to 8 p.m. And we have another interesting topic, that is surgery for obstructive sleep apnea. With this, friends, let us welcome our new Maestro, Dr. Chidanand, Dr. Chidanand Devasamudra, who also happens to be a good friend of mine, and he is a rhinoplasty surgeon from Bangalore, and he owns his own hospital, Akshay Rhino Dent Hospital, Bangalore at Sahkar Nagar, and he is one of the very fast upcoming and national level rhinoplasty surgeon. Welcome, Dr. Chidanand. Unmute yourself.
Thank you, sir.
Yeah, Chidanand. Yeah, welcome, Chidanand. I can read your CV, personal bio from your this thing from your curriculum vitae, but let it make us more interesting. Let it hear from your mouth. Okay, please tell me your journey, where you started your medical career, your undergraduate career, where you did your post graduation, how you developed interest in rhinoplasty surgeon, and where and how did you get the training in rhinoplasty surgeon? Let us hear from your mouth.
Yeah. First of all, thank you so much for the opportunity to share my few views on rhinoplasty. I did my medical school education from Mysore Medical College from 1997 batch. Then I did my master's in ENT, MS ENT from Bangalore Medical College. In 2006, I joined, and 2009, I finished. Later, I joined the fellowship program in Shimian Rhinoplasty Clinic. It is in Seoul, South Korea, under the mentorship of Professor Jung Dong Hak. So I worked with him for 1 year, and then I later came back to Bangalore, and I started my own practice in North Bangalore. Along with that, I worked few years in few medical colleges as assistant professor, and I learned a few more skills from different surgeons. Then in meanwhile, I was doing surgical workshop, live surgical workshops in and around Bangalore, Andhra Pradesh, Telangana, Hyderabad, like that. And wherever there is rhinoplasty workshop, the moderators and the organizer used to call me for my contributions. So, and wherever there is opportunity, I go there and I contribute a little bit from my side. And if anybody asks for any help or they want to learn rhinoplasty, I am at my service. I go to any place to teach, and I've done more than 10 live surgical workshops till now. I like teaching, so whenever there is opportunity, I will present my presentations and my videos.
Yeah,
Thank you,
yeah,
sir.
I've seen some of your live surgeries, and also you operated at our hospital. You've done a
Yes, sir.
wonderful job, Dr. Chidanand. So, how
Yes, sir.
was the training at Seoul in South Korea with that Korean professor? You had opportunity to do live hands-on work, or you can just observe. How was it?
Yeah, it was an interesting story, sir. I joined in 2009,
Yes.
2009 August.
Yeah.
At that time, there was a swine flu pandemic was there.
Okay.
So I was most of the Bangalore doctors, they got opportunity, but somehow I was the seventh person to contact. Dr. Pradeep Kumar, Men's Hospital, is the one who initiated this program.
Okay.
So yeah, he has contacted many doctors. Because of some reasons, nobody was like they want to go to Korea because it's a new place.
Yes.
A lot of confusions and food problems, all those things.
Mm-hmm.
So I was searching for the job at that time.
Okay.
After finishing my post graduation, I approached Dr. Pradeep Kumar,
Mm-hmm.
and he immediately told me there is one fellowship program in South Korea. There is one doctor called Dr. Jung Dong Hak.
Yeah.
He's a famous rhinoplasty surgeon.
Mm-hmm.
If you are interested, like if you have any interest, you can join the fellowship program.
Okay.
So I was like, I was searching for the job, and without any second thought, I joined it. I just said, "Okay, sir, I will go."
Okay.
So he was happy, and immediately I got the invitation letter from the Shimian Rhinoplasty Clinic.
Mm-hmm.
In the next week only, I joined the fellowship program in Seoul, Gangnam. It's a
Okay.
downtown in Seoul. It's a nice place. But I used to work from morning 6 o'clock to till 8 o'clock, 10 o'clock. I never used to see sunlight for few days, 5 to 7
Okay.
days. Yeah.
Okay. Okay. So you have to
So
put a lot of hard work there.
yes, sir.
Yeah. Yeah. I know. I know.
In
That's most
2009
important.
August, I joined.
Mm-hmm.
Initially, there was only observation for few weeks.
Okay.
It took me a few weeks to understand what is the basics of rhinoplasty and what they are going to do, and
Mm-hmm.
what are their techniques, and what are the instruments they use, what are the sutures they use.
Yeah.
And then first few weeks, just I was familiar with the doctors and nursing staffs over there.
Okay.
And first month, I just did a dressing for the
Okay.
patients.
Mm-hmm.
So this is how the fellowship program started. I did a
Okay.
dressing for the post-op cases.
Okay.
And
Okay.
then in the second month, my professor started giving me suturing. He
Okay.
started giving me suturing first. He told me to learn suturing first.
Okay.
Okay, so suturing, different techniques like simple sutures, continuous sutures, interpret sutures, all those things I learned for 1 month.
Mm.
So the third month, he started giving me the flap elevations,
Mm-hmm.
giving incisions.
Okay.
Okay, so the fourth month, I started doing complete flap elevation and septoplasties. Flap
Mm-hmm.
elevation of the mucopericardial flaps of the septum. The fifth
Yes.
month, he
Mm-hmm.
started giving me osteotomies.
Okay. Okay. Okay.
Okay. So 6 month, I was doing 6 month. I was doing complete from incision to the closure. I was doing alone. I'm alone.
Okay.
I'm doing. So he was coming and observing what I'm doing.
Okay.
So in between, he used to take me to different places like China, Taiwan,
Mm.
Philippines. So in such places, directly from airport, we used to go to operation theater and start doing procedures. I
Mm.
used to elevate the flap. He used to come and do the osteotomies, fine work, Diplasties, and he will go to the other surgery. And
Okay.
he used to suture. Like that, we used to do 10 to 15 cases per day.
Mm. Mm.
So that's where I learned, I picked up my speed of surgery.
Mm.
So later, after 6 months, he started giving me revision cases.
Okay.
So revision cases are difficult because you don't get proper plane and a lot of bleeding and anatomy will be distorted. So Later, seventh month, I started doing rib cartilage harvesting. So
Okay.
for the revision, for the reconstruction surgeries. So like
Okay.
that. So we are doing, and then later I started seeing the reconstruction surgeries like forehead flap techniques,
Okay.
sublabial
Okay.
flaps, cheek flaps,
Mhm.
all those things we started. And then at the end, at the end of 1 year, I was like, I felt like, okay, this is the time to go back to my country. So, so I came back to Bangalore and I started my practice.
Yeah, interesting story. I think that is the way one should be learning. We can't do one surgery, one particular surgery from skin to skin and learn everything in one go. That should be a gradual, graded learning process. I think that was a fantastic journey you had and a fantastic opportunity you had at Seoul. It's an odd place. We
Yes.
hear people training from Europe and America. Getting trained at Seoul is altogether a different experience. I can understand. So, how
Yes.
did you manage food there?
Yeah, I used to earlier, like when I joined a fellowship, there was like I had few pockets of some Indian food, and then somehow I managed it. But for a vegetarian, it is hell there. You don't get
Yes, yes,
vegetarian food
yes,
there. But
yes.
I'm okay. I'm okay with the other foods, and luckily I got a few software engineer friends there.
Okay,
They
okay,
helped me. They were cooking the food, and somehow I managed for 1 year, sir.
okay, okay, okay. That's
That is a
interesting
different
story.
story. I will
What
discuss
I
some.
want to ask you a personal question. Were you married then?
No, sir, I was not
No. So
married at that
what if
time.
some Korean girl, fell in love with you and proposed to get marry you and asked you to settle down in Seoul? What you would have done?
No, no, it is difficult, sir. It is difficult for me personally. I don't feel like.
Okay. Well, I was just joking because I have some Korean South Korean friends who visited as Rotary exchange program. Okay.
Yes, sir.
Yeah, I know. That's a fantastic journey, and it should be a motivating factor for many other junior colleagues who are here. They should also put up a similar kind of hard work to be there where you are today. Really proud of you for that. The thing. So with this, I think we can start the program.
Yes.
Okay, let the show begin, and you can share your presentation now. What I'll do is let me make you the co-host. Make co-host. Yes, you are co-host now. You can share your presentation. Let me. I'll stop my sharing. Yeah, go ahead. Share your presentation.
Shall I share my
Yes, sir.
presentation, sir?
Yeah, go ahead. Go ahead. Now you are a co-host.
Okay, just a minute, sir.
Yeah.
Can you see my
Not it. Yeah.
Can you see my slide, sir?
No, not it. Not it.
Not it. Okay,
Not
just
it.
a
Yeah.
minute.
Go to share screen.
Yes, sir.
Share that PowerPoint presentation. Yeah, it's coming. Yes, yes, we can see now, and you can bring the first slide. Yeah,
Yes,
yeah,
sir.
yeah. Okay, okay,
Okay, sir.
okay.
My presentation.
Mm.
You said it's like the surgical procedure, the external rhinoplasty for crooked nose.
Yeah, yeah, yeah. We
So
emphasize on the video, but you
yes,
can the salient features you start with PowerPoint presentation, then we'll go into the video.
okay, sir.
Yeah, yeah.
I will mainly focus on the crowd which are who are trying to learn the rhinoplasty,
Yes, yes.
who are who they want to do they want to take up rhinoplasty as their specialty.
Yeah.
So I will take at least 40 to 50 minutes for the presentation. Is
Go
it
ahead,
okay?
go ahead, go ahead.
Okay, sir. Thank
Yeah,
you. Thank you. Thank you.
yeah. But we're going to
Uh,
stop you in between to clarify any doubts, anything.
sure.
Now the participants they can raise their hand whenever they have some doubt. Okay.
Okay, sir.
Yeah,
Anytime, any
yeah, yeah.
questions, any doubts, you can ask.
Yes,
You can interrupt me anytime.
yes, yes, yes. Thank you
Okay.
so much. Yeah.
Okay.
Go ahead.
So this slide I have put because this is what you are doing. You are creating light for the others, and that we naturally light our own way. So
Yeah.
the teaching program, what you are doing is fantastic. I really appreciate
Thank you.
work you
Thank
are
you.
doing,
Yeah. Yeah.
and as a your work like in your program, you are helping us, or you are giving opportunity to share our knowledge. Thank you so much, sir.
Yeah, yeah, you're most welcome. Yeah.
Yes, sir. So this slide showing the different specialities for ENT surgeons. So there are different specialities which, as a beginner, I was having all these options. Then when I got fellowship in rhinoplasty subject, I took rhinoplasty itself as my specialty, and I am working only on rhinoplasty right now.
This is a very interesting slide. Can we go back to the slide? See,
Sir.
the otorhinolaryngology is a vast field and sky's the limit. We can do so many things here. Okay. Really, we are blessed to be in this specialty, I believe. Somehow, despite this, so many opportunities, I still see ENT is the least preferred specialty among many people, even now. But
Yes.
I consider this to be one of the topmost specialty. Yeah, go ahead.
Yes, sir. So, as a rhinoplasty surgeon, I feel you must have passion towards the subject and compassion towards the patient. Whenever you get a patient as a rhinoplasty patient, or a crooked nose or a saddle nose, they will have some kind of a low self-esteem. So you have to talk to the patient, and you have to tell the patient like what we can do to the patient.
Yes.
And as a surgeon, you must fit enough to work for 8 hours, 10 hours a day without any without any stress, or you feel tired. You should not be tired, because rhinoplasty, where you have to spend a lot of time in OT, sometimes you have to do reconstruction work, sometimes you have to harvest rib cartilage. In such conditions, your fitness matters a lot.
Yeah, yeah.
So ENT practice and rhinoplasty, you can work together. If you don't get enough rhinoplasty cases in the beginning of your career, you can do other general ENT also, general ENT practice. And as long as you are happy with the practice, you can continue both.
Yes.
Okay. When you get a rhinoplasty case as a crooked nose or a saddle nose, the case selection is an important thing when you are a rhinoplasty surgeon. Sometimes patient may have minor deformities.
Yes.
Okay, such conditions, in such cases, it is difficult to satisfy the patient. Okay, in such conditions, it is better to avoid such minor deformity cases if you are a beginner.
Yes.
Okay.
Very important point, I think.
Yes, sir.
Very
So
important
if it is a crooked nose, if it is a saddle nose, it is easy to give some result. It is easy to correct the deformity.
Yes.
Okay. The preoperative preparations also important. You must know I have heard from Dr. Prahlad before, you have to do surgery 3 times.
Yeah, yeah.
So in mind, you have to read once. You have to do the surgery in mind, and in the OT also you have to do it once.
Yes.
So that is the thing I do. Like before surgery, I do the surgery in my mind. First, I will think what are the things we have to be there in the surgery, in the OT, and what are the things we have to prepare for the patient. As a surgeon, what are the preparation I have to prepare, and in the hospital. So all those things we have to be well in advance. We have to prepare it.
Okay.
Okay. So then post-op care and follow-up also important, because most of the time patient will not take proper medication and they'll end up in complications.
Yeah.
Okay. The follow-up is important because you have to see what is going on, like what surgery you have done, what are the results you are going to get, and what wrong things you have done. So the follow-up is important to know your results, as well as the patients will come back with more patients. So if you call the patient for follow-up, they will bring some more patients for rhinoplasty.
I think this is a profound statement you have made.
Yes, sir.
Patients will bring patients. That is how the word of mouth should spread. We are not supposed to advertise ourselves. I think this is a great way to get more patients, isn't it? I think that you have made a fantastic statement to begin with. So thank you very much for that. Yeah, go ahead.
Yes, sir. Marketing is nowadays, this is a new new option, like it is a new thing for most of the senior surgeons. There are a lot of platforms for marketing yourself. So it is all up to you, because some people go for video websites, they go for YouTube videos. There's so many things are there to market yourself. When I think that is right now it is essential for any rhinoplasty surgeon. And you have to do teaching programs, and you have to build your own network, so that you have to get, if you are a good rhinoplasty surgeon, if you don't know, if you tell your colleagues, if you talk to your colleagues, and if you make more teaching programs, and if you talk to the other doctors, they will refer to you. So otherwise,
Yes.
people will not be knowing that you are doing a good job.
Yes.
Okay. Okay, next slide. This is for the postgraduate students, for the college staff, or the staff who are planning to go for rhinoplasty as their specialty. Most
Yeah.
of the postgraduate students, they are not aware that there is a rhinoplasty, or we can do good proper cosmetic rhinoplasty in ENT specialty.
Yeah.
So for that, we need sensitization. So our seniors, our staff used to sensitize us, like there is something called rhinoplasty, we can do it. So
Mhm.
most of the time, if they are interested, they used to do it. The postgraduates used to do a journal club. They used to present so many presentations on rhinoplasty. So
Yes.
there, first begin with, you have to septoplasty. If you have to if you want to learn rhinoplasty, it is better to do septoplasty first. You must learn septoplasty and then go to
Yes. Yes.
rhinoplasty.
I think this is
Further,
very
all those
important
things.
statement you have made, Dr. Chidanand.
Yes, sir.
I think this is everybody should, junior colleagues should write it down. Do a good septoplasty before you get into a rhinoplasty. Profound statement. Another profound statement you made. Continue. Yeah.
Yes, sir. And the postgraduates needs guidance. They need mentorship. They must
Yes.
know, like, they are doing right or wrong. They must have some mentor.
Yeah.
So, and they have to do more number of cases. As they get more number of cases, they will come to know what they are doing, like what they are, whether they are doing right steps or not.
Yeah.
And then they have to have proper instruments. They must have all the instruments, like for suturing, for incision, for osteotomies, for rib cartilage harvesting. All those things they must have in well in advance. They must keep it, and then they must know about the complications also. They must
Yes.
anticipate the complications whenever they go for a surgery.
Mhm.
So they must anticipate, and they must be ready with the treatment of complications. And then
Yes.
finally, follow up. As I said earlier, follow up is important for any surgeon. So
Mhm.
they will come to know the patients if they come again and again. So your practice will build up.
Yeah.
Okay. So what are the things you must do as a postgraduate or as a beginner? You must attend workshops, you must attend CMEs, and if possible, cadaveric dissection. If you are working in a medical college, the fantastic opportunities will be there. You
Yeah.
can talk to forensic department, and you can go and you can work, and you can do cadaveric dissections. You can see videos, but videos, as long as you do surgeries, it is difficult to feel the steps. Okay, so it is better to go for cadaveric dissection, and then work with your seniors, and you can work as a resident with senior rhinoplasty surgeons, and you learn few techniques, and then you can start your on your own. There are few fellowship programs in India and abroad. You can go to the workshop or fellowship programs, and you can learn it.
Yeah, I think very important point. I think this particular slide, I request all the junior colleagues to take a snapshot and save this slide. I know very important points made by Dr. Chidanand. Really, it's a fantastic thought. I congratulate you for this, Dr. Chidanand. Go ahead. Yeah.
Okay. What are the challenges for the young budding ENT surgeons? Like if they want to practice, if you want to go for rhinoplasty as their specialty, if you are a private practitioner, you don't get rhinoplasties on day one or beginning. You cannot get, like, every day you will not get rhinoplasty cases. It's difficult to get general practice, general cases only. It is difficult to get if you are a private practitioner. So how to what are the things you must know? How to improve the number of cases, that we will talk later. So number of cases will be very, very less. Even I have seen most of the senior surgeons like Dr. Madhusudan Rao, Dr. Prahalad, or Dr. I've seen different senior surgeons. They say they see every day, they see around 100 patients per day. Okay. They get 1 or 2 cases per day, or they get 1 or 2 cases per week, 1 or 2 rhinoplasties per week. So such a narrow field, and some patients don't go for it. They don't go for rhinoplasty surgery. They want just only nose block. They want to correct only nose block. So in such conditions, it is difficult to get more number of cases. And instrument for the young budding star ENT surgeons, very costly. They expensive instruments. If you go for a good company like Medicon, it will cost around 2 to 3 lakhs. If you go for a Starch company, it will cost around 4 to 5 lakhs. So for the budding ENT surgeons, it is difficult to buy instruments. And one more thing is cost of the surgery. If you are doing as a beginner, if you are doing rhinoplasty, it will take a lot of time because you will not be knowing what are the preparations, how you go, and the speed of the surgery will be slow. So it will be like 3 hours to 6 hours, to sometimes 7 hours. The cost of surgery will increase. When you are doing in a private hospital, the hospital will charge 1 hour per hour, they will charge 8,000, 10,000. So the cost of the surgery will go up to 2 lakhs, 3 lakhs. So that is also you have to keep in mind. Whenever you are doing a rhinoplasty as a beginner, better you take a help of senior surgeon, and you must learn how to do fast, how to do the surgery fast. So if you increase the speed of the surgery, the cost of the surgery will also come down.
Yeah.
So this is what I want to say.
Yes, yes. I stress upon this point all the time to our training fellows also. That is, time is money.
Yes,
We
time is
can't go
money.
on doing a surgery forever in operation theater and block the operation theater. We have to share our time for other things also. I think
Yes.
this is a third profound statement you have made today. Fantastic. Go ahead. Yeah.
So for one more point, I want to add, general ENT practice for ENT surgeons is like bread and butter. So if you are planning for rhinoplasty as a specialty, I feel it is better to do general ENT practice also. And whenever you get any case, any surgical case, whether it is a rhinoplasty or is a tympanoplasty, don't refer the case to anyone. You have to do it. You have to do it in your hospital. The patient has come for you, so they have to feel that you are doing the surgery. You call any senior surgeon, you call any senior surgeon, and you get it done by the senior surgeon, or you also do few steps, and then at the end, if you feel difficulty, you can the senior surgeon will take over. Okay. So in that way, you will not lose the patient. If you are planning for private practice, this is what I do. I don't refer any patient to any other hospitals. If I have, see, now I have my own hospital, my own OT. I call my seniors. Okay, and then if rhinoplasty is there, I will do on my own. If the something like some kind of a facial nerve decompression, or something like stapedectomy, in such conditions, or head and neck oncology cases, I call a specialist. And in that way, I don't lose my patients. And then when you are planning for rhinoplasty as your specialty, you can begin with open septoplasty. If there is minor septal defect or minor septal deviation, if the patient is coming for septoplasty, you can try open septoplasty. You can do a palmar incision, and you can elevate the flap. In that way, you can practice yourself how to do open septorhinoplasty. So this is also one of the option we give it to a newcomer or a budding ENT surgeons.
Important point. Yes.
So then this is the slide showing the learning curve of a rhinoplasty surgeon. As I said, you have to do first septoplasty. You must know how to do septoplasty, how to do give incision, how to elevate the mucoperichondrial flap, and then start doing functional septoplasty, functional open septorhinoplasty. In functional septorhinoplasty, you are correcting only the nose block. You are going to give a patent airway in functional open septorhinoplasty. There you can correct caudal dislocations. You can do it slowly, you can do it. But if the patient is not worried about the appearance, the patient is not worried about the shape of the nose, you can try something like rasping, doing some caudal dislocations, some corrections on the nasal framework. Okay, so this is how you learn the cosmetic. Like next step is cosmetic rhinoplasty. If you do functional septorhinoplasty first, if you know how to give good airway by doing open septorhinoplasty, elevating flap, then that is one step. The next step is cosmetic rhinoplasty. If the patient is worried about the shape of the nose, then you have to understand how you have to, like, how to do a tip plasty, how to do osteotomies, how to do something like spreader graft suturing or cap graft. All those things will come under tip plasty. Okay. After learning all these cosmetic work like tip plasty, osteotomies, then you can go to the next level. The next level is correcting the congenital deformities, or correcting something like facial
Yeah.
deformities, or something like tissue loss. The next level is reconstruction rhinoplasty. That is the, I think that is the top of the learning curve. In the reconstruction rhinoplasty, you have to know how to harvest the rib cartilages, how to harvest the conchal cartilage, and how to harvest the flaps, how to do the harvest like forehead flaps or nasolabial flaps or cheek flap. All those things will come under reconstruction rhinoplasty. So my journey started from septoplasty. When I was a resident, I started doing septoplasty first. And then slowly, I started doing functional rhinoplasty, and then cosmetic rhinoplasty, and then reconstruction rhinoplasty. This is how the learning curve is. If you are a beginner, don't directly jump on reconstruction rhinoplasty. If you are not trained enough to harvest the forehead flap, harvest rib cartilage, you will have a tough time. So this is what I feel.
I
It is.
think this is another fantastic slide, Dr. Chidanand. I think I
Thank you.
encourage junior colleagues to take the snapshot of the slide and keep it. Fantastic. Go ahead. Yeah.
Yes, sir. This slide I show here. So I was having a general practice in 2009, 2010. I was getting once in a while, some senior surgeons used to send me rhinoplasty cases. This is like once in a month. Once in a month, I used to get cherry, like rhinoplasty is cherry. That's what just my imagination. Later, I doing rhinoplasties everywhere. I used to travel different places, and people are referring me rhinoplasty cases. And now I am getting more than 10 cases per month. So that is how I'm getting more cherries nowadays.
Wow. That's an achievement, Chidanand. You really deserve
Thank
it.
you. Thank you, sir.
I'm really proud of you. Go ahead. Yeah.
Okay. So, and I don't feel like stress. I feel like doing rhinoplasty is my passion.
Yeah.
So whenever there is a case somewhere in Vijayawada, somewhere in Anantpur,
Mhm.
or somewhere in Hassan, so I just travel. I just go there. I enjoy traveling, and I go to the patient. I talk to the patient. I enjoy surgery, doing surgery, and then follow up. All those things. I enjoy it. That's how I don't feel like stress. So traveling all the night, early morning, going and operating in the OT, and then coming back in the afternoon and starting my practice in my hospital at 4 o'clock, 5 o'clock in the evening till 10 o'clock. I do the OPD. So I don't feel like stress because I like it. It's my passion. So somehow I'm not having any touch wood. I don't have any issues with the health or anything because I enjoy the work.
Yeah.
So this is how you should be. If you are doing rhinoplasty work, you must enjoy it.
Yes.
Okay.
Important point.
Next,
Yeah.
next part is interdisciplinary approach. So whenever you get a rhinoplasty case or any, sometimes you don't get only the nose deformity. You may get something like some scar over the nose, some scar over the forehead, or sometimes you may get some double crease in the uh, some lower eyelid problem, some lower eyelid bag, something like that, or some injury road traffic accident cases. They may get some leaf out fractures. Such conditions, you have to take help of other our colleagues like plastic surgeons, ophthalmologists, or oromaxillofacial surgeons, neurosurgeons. So all these intensivists, all these colleagues, our friends will help you to develop your practice. So if you want to have any help or anything, you want to take help from the other specialty, don't hesitate to call them. So you work as a team, then your practice will build up. Okay.
Yes, very important. Yeah.
The next slide, the successful rhinoplasty. This is important slide. You must, the successful rhinoplasty begins with careful patient selection, preoperative preparation, planning, and evaluation of the patient requirement. This is important because the patient selection, most of the time, the selecting a patient itself will decide whether you are successful, you are going to be successful or not. Okay, so that is important, and all other things like planning, evaluation, all those things will also matter.
Yes, very important. Yeah.
Yes, sir. Perfect nose or normal nose? There is, I don't feel there is a perfect nose. So most of the patient come to me and they will say, okay, you are a senior surgeon, you are having experience of 14, 15 years. Can you give me perfect nose? This is the question I get when the patient come and sit in front of my in my office. Can you give me perfect nose? I say there is nothing called perfect nose. You don't get, there is something called perfect nose. There is nothing like perfect nose, but there is something called normal nose. Perfect nose, I don't know what we cannot define perfect nose, because each individual is different and each individual will have facial aesthetics, different facial aesthetics, and depending upon their ethnicity and the geographic placement, they will have different kind of nose. But normal nose, yeah, there is called something called normal nose. What is normal nose? If you look at the face of the patient, the nose should not get attention. It should not get attention. You have to look at the eyes of the patient. If the patient, if you are looking at the nose of the patient, then there is something, some problem in the nose. You, most of the time when there is a deformity in the nose, then only it will get attention. So this is what I explain to the patients whenever come. They were most of the patients, like some celebrities, they come and tell me, can you give me perfect nose? I said, I deliberately say, no, I cannot give perfect nose. There is another thing like perfect nose.
Yeah, I think this
Okay.
is an important point you stressed upon, Dr. Chidanand. I think
Yes, sir.
the patient should have this understanding, clear-cut understanding of this point. And also we should have the humility, being surgeons, we should have an humility and we should accept that we can never give a perfect nose. I think that is a very important point you have made. All junior colleagues should understand this. Yeah, go ahead. Yeah.
It's all in the perception or in the mind of the individual.
Yes.
So
Yes.
yeah, so this slide I'm showing, you know, how many of you know Michael Jackson had a prosthetic nose? In the end of his life, he was not having the nose itself. So he was using prosthesis. He was using some nose prosthesis. The only piriform aperture was there. So he was our Professor Jung's patient. He came once to Seoul and he had a consultation, but he could not come for surgery. Before surgery, only he died. So he had a body dysmorphic disorder problem. He has undergone 17 times. He has undergone rhinoplasty 17 times. Such
Wow.
a
Wow.
disaster. It's
Mhm.
a disaster for him. He was not having any nose at the end of his life.
Mhm.
The same, it is the one part of the story. I've seen many people who are having saddle nose, bulbous nose, crooked nose, like Akhilesh Yadav having crooked nose. They're happy with their nose. Look at their face. They're happy. They're smiling. They're not bothered about the shape of the nose.
Yes.
So this is all. It's in the perception of the patient mind.
Yes.
Okay. This slide showing celebrities like she's a cinema star. She's a Bollywood star. She want to get. They want to know. She want to look better.
Mhm,
She has undergone series of plastic surgeries, facial
mhm,
plastic surgery like a brow lift or rhinoplasty, and
mhm,
then malar implant, cheek implants. So
mhm.
now she's looking like this
Okay.
because she requires it. She is a celebrity. She want to go for a movies and all. It is okay for them. Okay,
Okay.
so this is how you have to understand. So
Mhm,
some patients want to go for extreme plastic surgeries, like multiple plastic surgeries. That means they are not normal.
mhm,
If they are celebrities like movie stars, then I think it is acceptable.
mhm.
Okay, assess before putting knife. Like whenever you are okay, you have selected the patient for rhinoplasty. So basic things you must know as a beginner. You must know the anatomy of the nose. You must know the framework like nasal bones, for frontal process of maxilla. All those things you must know. The bony
Yes.
and cartilaginous framework and skin over the nose. This is also important. If the skin over the nose is thick, it is difficult to very difficult to manifest your framework changes in the nose.
Yes.
Sometimes like if the patient is having oily skin, thick skin, if you want to go for if you want to do a tip plasty, sharp tip plasty, it is difficult. Okay,
Yes.
and the consistency of the nose also important. You must feel the nose whenever you go for a surgery. Before surgery you must feel the consistency. If the patient is having a good septal cartilage, then you will have a recoiling, spring like feeling. When you touch the nose, you can feel the resistance. That means you will get enough septal cartilage for reconstruction. You will
Yes.
get enough cartilage for septal spreader graft or cap graft. If the patient is not having resistance, if the nose is going easily inside the nose, then you must think that the septal cartilage is not strong, and you may not get enough cartilage for reconstruction. Then you must plan for conchal cartilage or something else like rib cartilage. All those things you must anticipate before surgery. And facial aesthetics is also important subject. It needs a lot of time to explain facial aesthetics because there are a lot of things like terminologies are there. Facial aesthetics is a different. We will talk some other day. Uh,
Yes.
okay, these are the vital structures. Important vital structures come in between in the way when you do osteotomies. These are the only important structures like lacrimal sac, lacrimal gland, and the orbit, eyeball.
Yes.
Okay. So whenever you do osteotomies, you must feel the medial border of the orbit, lower border of the orbit, and the junction of the medial and lower border of the orbit. And then you can leave 2 to 3 millimeter the bone, and you can do the osteotomies. Okay, this is the important thing. You will not injure the lacrimal sac when you are in a proper plane.
Yeah. And also
Okay.
while doing the lateral osteotomy,
Yes, sir.
preventing injury to the nasolacrimal duct is also very important. We are more medial to it, right?
Yes, sir.
Yeah. Yeah.
Most,
Okay.
if you are deliberately going and if you are go and if you want to injure the lacrimal sac, you have to identify and then only you have to hit the lacrimal sac. Otherwise,
Yes. Yes.
when you are
Yes.
doing conventionally, most of the time you will not injure the lacrimal
Yes.
sac.
Yes. 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 Important.
Okay. Conducting consultation, like when you get a patient of rhinoplasty, how should be your questions? Like when the patient comes to you and sit in front of you, you don't ask yes or no questions. You should not ask yes or no questions. You
Yes.
must ask open-ended questions.
Important.
Open-ended questions like what brings you to me?
Mhm,
What is your problem?
mhm,
What bothers you about your nose?
mhm,
These are the open questions. Okay. So when you ask like this, you will come to know. what exactly patient wants. Okay, sometimes patient attenders like husband or the wife will bring the patient, or some would be will be like some parents will come and bring the patient and they want to go for rhinoplasty. So I sometimes patient will not be interested in rhinoplasty, but some other person will influence and bring them to you for rhinoplasty. In such conditions, you should be careful. You should not
Yeah.
operate in such patients.
Yeah.
Okay, so you must ask the questions in such a way to get answers for these two questions. Can I solve problem of the nose? Will the operation solve the patient problem? These are the important things you must know.
Yes.
If the patient himself is coming or herself coming for rhinoplasty, this is a good sign. If somebody else is coming telling that their nose is not good, go for rhinoplasty, it is not a good sign.
Yeah.
Okay.
Very interesting point you made.
Yes.
Interesting. Yes. Good.
So open questions like, how do you feel about your nose? What made you to go for surgery? What do you do? What do you know about the surgery? These are the questions you must ask. Then they will come out with their own ideas. They will tell, okay, my colleagues are not happy with my nose. I'm having some nose block. All those things they will come, and then you can plan the surgery accordingly. And you will come to know the insight of the patient. The insight is very, very important. If the patient is mentally stable, they don't have any body dysmorphic disorder, then you will be safe. If the patient is having something like depression, some kind of family problem, some personal problem, something like that, then patient will not be happy after the surgery. You have done wonderful job. You would have done wonderful job. Your results are good, but if they have something like depression, some family issues, all the blames they will put on you. They will tell, after doing surgery all these happened, after surgery I got divorced. All those things that I have seen, I have experienced. So you should be very careful when you go for a surgery. You must inquire about all these things.
Very interesting. Very
Okay.
important point. Yeah.
Yes, sir. Okay, so if you want to know all those things, you must spend time with the patient. You must identify, avoid facial dysmorphic syndrome, and you must tell the patient about the post-operative results, complications, and need of revision operation. This is important point. I've seen patients coming after 3 years, 4 years, 5 years. They come and they want to go for revision. They want to go for better nose, and sometimes they'll come and say, I want to get little bit better looking nose. At that time, patient will say, sir, you said in one sitting only we will do all the corrections. So it is wrong. See, as the age progresses, his financial or his social status or his physiological status will change. So in such conditions, you must tell the patient that you may require one more revision. You may require one more, or you may require after 3 or 4 years, or we don't know when you want revision, but you may require revision surgeries in future. For that, you must tell the patient about revision surgeries. You must take consent that you may require one more revision or two more revisions whenever if you get some kind of complication or some deformities, residual deformities. Okay.
Important. Yeah. Yeah. Okay.
Realistic expectations. You must understand the patient insight, and if the patient is having crooked deformity or some saddle nose, which is obvious, then it is a realistic expectation. If they have come for rhinoplasty, that's good. Okay. If the patient is having good looking nose, they want some changes, some minor changes, or they will come with the photographs. They'll
Yeah.
come with some celebrity photographs. It is not a good sign. The patients are not good patients. If they bring some photographs, they will have their own imaginations.
Yes.
So in such conditions, it is better to avoid doing surgery for such patients.
Yeah. Another important point you stressed upon this concern, patient coming with a photograph.
Yes, sir.
Those are the patients who come with lot of expectations, isn't it?
Yes.
Yeah, yeah, yeah. They should have a realistic expectations. I think we were stressed upon the informed consent about requirement of future surgery,
Yes.
more procedures for other facial deformity, dysmorphic syndrome, deformities. We should take well in advance. I think this is another golden statement you have made, Dr. Chidanand. Fantastic. Go ahead. Yeah.
Yes, sir. I have seen few patients after rhinoplasty, they will come with a nose block. They will
Yes.
have nose block.
Yes.
When you do a diagnostic nasal endoscopy,
Mhm.
you will see polyps in the nose.
Yes.
Very difficult to explain them. Sir, you said we will not get any nose block in future, but
Mhm.
now I have got a nose block.
Yes.
So it is because of some sinusitis or it is because of some nasal polyposis.
Mhm.
That is not our problem. Maybe they would have some allergic problem. So again, here you have to talk to the patient and you have to take consent for revision surgeries and some other problem, maybe because of some sinusitis, polyposis, you may get nose block. That also you have to mention
Yes.
the patient.
Yes.
So after taking all those things, like after asking all the questions, if the patient is okay for the surgery, I think you feel that, okay, this patient is for rhinoplasty, then you have to take photographs. Very, very important because you must know the nose is a three-dimensional structure. So it is projected structure over the face. Okay, it is a most visible part of the human body. Whenever you see any individual, the nose is the first thing which you see. Then you will see the eyes. Okay, for that you have to take photographs in 7 views. 7 views: the frontal view, lateral view, oblique view, basal view, and bird view. I will just take the photographs. See, this is how I take photographs. This is the profile view or the frontal view, this is the basal view, and the aerial view. So the angle little bit change, but the background is also important. See, the background should be light blue or light green, should be uniform, it should be pleasant. So this will help you to uh, sh- uh, give a better presentation. When the patient asks for show me some pictures, what the surgeries you have done. So when you show the pictures, the patient feel happy. Okay, the background is important. It should be like light blue or light green. Sometimes practically, sometimes it is difficult. So in such cases, there are some exceptions. See, this is the lateral view. The lateral view, you must see the angulations, the frontonasal angle, nasolabial angle, and you must see the eyebrows of the opposite side, the right and left lateral view, right and left oblique view. The oblique view, the tip of the nose should come in line to the cheek. This is how I do take photographs. And then pre-op and post-op photographs also I take like this. They should be similar. The angulation should be the same. Practically, it is difficult, but you can try it. You can do it. So this is how the lateral view. You can see the hump removal or tip rotations. You can differentiate. You can make out the difference pre-op and post-op. The nasolabial angle is increased here. It is decreased in the pre-op photographs. The oblique view, the lateral view again. Okay, so when you take a photograph, you must assess the photographs. You take the photographs and study the photographs of the patient and look for the angulations like frontonasal angle, nasolabial angle. This will help you to assess the length of the nose. And you must know about the facial aesthetics, like 1/3 rule. The forehead should be 1/3, and nose, and the from nose to the chin 1/3. Like they should have equal dimensions. So all those things you will learn in facial aesthetics. This is a picture showing different deformities. If the patient is having saddle nose or the hump or the bulbosity. So this picture showing the saddle in the bony framework. Okay, so this picture showing supratip depression. In this picture, the saddle nose from top to bottom, like this is a full length saddle nose. Okay. Similarly, some patients will have only the hump in the bony fragment or bony cartilaginous junction. Sometimes patient will have a thick tip, that is called bulbous tip or boxy tip. Sometimes patient will have a hump or the extra tissue over entire length of the nose. That is the tension nose. Okay, depending upon the deformity, there are different types of rhinoplasties. There is a crooked nose, you have to do something called corrective rhinoplasty. If there is deviation nose, you have to do corrective rhinoplasty. If there is a saddle nose, then you have to do augmentation rhinoplasty. You have to use some materials to augment, increase the height of the nose. Like that, there are different deformities require different types of rhinoplasty. If the patient comes for only nose block, then it will be a functional rhinoplasty. If the patient has come for revision, like the patient would have done rhinoplasty, somebody would have done rhinoplasty, but patient is not happy, then it is a revision rhinoplasty. Some people will have tissue loss, some dog bite or some road traffic accidents. In such conditions, you may have to do reconstruction rhinoplasty. The pediatric septorhinoplasty is again is a different, entirely a different topic which needs a lot of time to discuss. It's a controversial. I think some other time we will discuss about the pediatric septorhinoplasty.
Important,
Okay.
yeah. I mean, a lot of possibilities are there and different aspects are there to the rhinoplasty.
Yeah,
Yeah,
rhinoplasty
yes,
is
yes.
not every individual, every case is
Case is
different.
different.
Every
Every
case is
case is
different.
different.
So,
Yeah, that is the point. Yeah, yeah.
yes, sir.
A very important
Yes,
point.
sir.
Yeah, go.
Yes, sir. So I will show few photographs to know the deformities. So this is
Okay.
the crooked nose. You can see there is a hump. There is a hump here, and there is a tip drooping, and there is a deviation. It is like a tension nose.
Okay.
This is one more deformity. This is a C-shaped deviation. C-shape to the right, C-shape to the left.
Mhm.
The post-traumatic depression in the lateral wall of the nose. This is again a post-traumatic C-shaped deviation, the depression in the lateral wall of the nose. This is one more deformity. See, in the most of the road traffic accidents or in the trauma cases, the entire nasal framework will be shifted to one side or posteriorly. Okay,
Yes.
so
Yes.
this bony framework they have shifted to the opposite side, the right side.
Yes.
This is again a deformity, the C-shaped deviation. And see here, the nasal framework, the bony framework is center. It is in the midline. They don't want any. It doesn't want any correction. But after keystone area, there is a deviation. Can you make
Yes.
out here? So in
Yes.
such
Yes.
conditions, only septal correction will help. There is
Okay.
no need to do for go for osteotomies. One more picture showing slanted nose. The entire framework shifted to left side, and the tip you can see you can see the tip lower lateral cartilage is developed more on the left side. That's why the nose looks deviated to the left side.
Yes.
Okay, the gross deviation. This is one more picture. Picture quality is not good. Please pardon me. I was old when I was a postgraduate student. I took these photographs.
It doesn't
This is
matter.
again.
It shows how you evolved with rhinoplasty. Doesn't matter. Yeah.
Yes, yes, sir. Thank you. Yes, sir. And this is one more picture when I was I was staff in a medical college. I took this photograph. He is having a slanted nose. This is again after trauma only, after injury. The entire nasal framework shifted to left side.
Yeah.
Okay, this is very difficult to operate, very difficult to give a straight nose, because when you do osteotomies and when you make the nasal framework, shift the framework to the midline, there is something called memory of the cartilage, memory of the nasal bones. It will again it will pull the nasal framework to the same position. So this patient had a same problem. We did rhinoplasty, we did osteotomies, transverse osteotomies, lateral osteotomies, everything we did when we pushed it to the opposite side. But patient came back after 3 months, 4 months. Again, the nose is shifted to the same side. So
Okay.
then I realized I think we have to do overcorrection. We have to push the nose to the opposite side, and then we have to do follow up every time. Every once in a week we have to call the patient, and we have to see whether the patient is having some deviation or not. And then we have to do something called massage. We have to push the nose to the opposite side, then the nose will become straight.
Okay, interesting. Yeah.
Yes, sir. So this is again, this is something, it looked like a saddle nose here.
Yeah.
Can you see the arrow? Can you see the movement of arrow, sir?
Yes, yes.
Yeah, there is a, it looks like saddle nose here.
Yeah.
It is not, it is a pseudo saddle nose, because there is a shift or there is a deviation of the nasal framework to the left side.
Yes.
When you correct the deformity, when you do proper medial and lateral osteotomy, this saddle will disappear.
Yes.
There is no need of augmentation. Okay. This is a saddle nose, proper saddle nose. You can see here, there is a depression in the middle 1/3 and upper 1/3.
Yes.
This is again one more saddle nose.
Yes.
This is a patient with trauma, post-traumatic. One more. Okay, yeah. See again, this patient is having saddle nose. This is a leprosy patient.
Yes.
With a saddle nose.
Yeah.
And this is an inverted V deformity. This patient is having inverted V deformity.
Okay.
Here, the patient don't want this inverted V deformity. Okay. The tip is developed properly, but the nose, the upper bony fragment is not developed.
Okay.
The nasal bones and the frontal process of maxilla is not developed properly. So in such conditions, the tip is fine. You have to do only nasal framework, bony framework you have to correct.
Yes.
Okay. So this patient is having only deformity in the only left nasal, left lateral wall of the nose. So she don't want any corrections on the other side and tip, everything is fine. She want only correction of this part. So yes, how to do it? So there are two options. One option is you can elevate the flap and keep a cartilage just over the depression.
Yes,
this is one thing. One more thing is you elevate the flap, cut the upper lateral cartilage from the septum and keep the spreader graft. You can keep the spreader graft, and by doing that, this depression will disappear.
Yes.
So in two options, I prefer spreader graft is a better option, because you keep the graft here, it will displace. It will displace over a period of time. It will go up or down or laterally. Then the patient will come back again.
Does it migrate even if you fix it with sutures, some sutures?
Yeah, suture will disappear after a few months, and
important point. Yes.
Okay.
Yeah.
There's something called hump and pseudo hump. This slide explains hump and pseudo hump. It looks like hump here.
Yes.
Actually, this is not hump. This is because there is a supratip depression. Can you see here?
Yes.
So this depression will give optical illusion. So
yeah.
You will get you feel like there is a hump. This is a post-septoplasty depression. After septoplasty, the supratip is having a dip.
Yes.
So here you have to give a proper L strut.
Yes.
You have to give a spreader graft and a proper caudal strut.
Yes.
By doing this, you are going to get normal nose.
Yes, important. Yeah, that's what some of these patients post septoplasty, they don't complain of saddling. They complain like there is some hump again, some swelling is there on the this thing, dorsum of the nose. Yeah, I noticed. I mean, these points which you're enumerating now, showing this, so beautifully illustrating. This comes with experience, I believe.
Yes, sir.
Yeah. Good. Go ahead.
Okay, so this is again. See here, there's a depression in the tip. In this picture, the lady with the nose stud, she needs again she needs a tipplasty, proper
Yes.
spreader grafts and columnar strut
Yeah.
that will improve the profile of the patient.
Yes.
This
Yes.
patient entire nose needs augmentation,
Yes.
and this patient needs upward tip rotation. You can see here the patient is
Yes.
having nasolabial angle is acute. The
Yes.
nasolabial angle is acute here.
Mhm. Mhm.
So if you rotate the tip upwards,
Mhm.
then the nose becomes straight and the nose looks good. Okay.
Yes.
So this is a picture showing
Mhm.
bulbous nose. This patient is a typical
Yes.
classical case for tipplasty. The tipplasty, you have to do
Mm.
a cephalic resection and doing interdermal suturing. All those things will help to this patient. This is a congenital deformity, the cleft nose patient. There is a cleft nose. It is a congenital deformity. This patient also require a proper tipplasty. Interdermal suture will help her.
Yes. Yes.
Pediatric septoplasty. So I've seen a
Yes.
lot of pediatric patients. I've operated also.
Mhm.
The problem with the pediatric septorhinoplasty is the cartilage is soft and fragile, and the chances of complications like septal abscess is more. This is where we have to avoid pediatric septoplasty,
Yes.
septorhinoplasty.
Mm.
And post-operative management is also, it is a difficult task. If the patient won't cooperate, they don't cooperate for suture removal, splint removal. So especially in Bangalore, the patients, the kids are pampered kids. It is difficult to handle kids. So, but sometimes if the patient is having obstructive sleep apnea or severe nose block, I tell
Mhm.
the patient to go for surgery, and I take consent for revision, maybe 2 or 3 times. Like after 18 years, after 25 years, patient may require one
Mhm.
more surgery. If they are okay, if they are willing, if they sign, then only I operate. I don't operate otherwise.
Mhm. Important.
Okay.
Yeah.
Then preoperative preparation for the patient. You must talk to the patient. You give all the whatever information is there. You give it to the patient like checklist. It is better to have a checklist, printed
Mhm.
checklist, and give to the patient.
Mhm.
Okay, and take consent for the surgery, publication,
Mhm.
and public display and the
Mm.
ads. Because you are, if you are a rhinoplasty surgeon, you may have to display the photographs in different formats, different
Mhm.
areas. So better to take consent for it.
Yeah.
Okay, and then phone numbers necessary, all the things like information you must share with the patient.
Yes.
And then financial and building requirement also important. You must be clear with the money part. You must
Yes.
tell everything in advance only. If the patient feel like if you are cheated, then the patient will not come back.
Yeah. Yeah.
So that is one more thing. Preoperative preparation for the patient, also all those things over.
Mhm.
uh, okay, highly trained staff, this is important. It will reduce the stress on the surgeon. If your staff is well trained, if the patient, if the staff anticipate your surgical steps,
Mhm.
anticipate well in advance, and they give instrument well in advance, then the speed of surgery will increase. You will finish the surgery fast, and the results also will be good.
Yes.
Preoperative preparation for a surgeon, what are the things you must prepare yourself? Instruments important, sutures, nasal splints. I've seen many a times we would have done all the surgery well, but you are not having splints. The splint stocks are over. You don't get splints immediately. Then you
Mhm.
have to go for POP casting and all those things. So
Yeah.
it may not give good result at the end, just because not having splints. You may not get the nasal framework in a desired position. Okay.
Important. Yeah.
So all those things like number blades and nasal packs. Nasal packs also important. So the
Mhm.
packs, whatever you use, like Avalon or Mirosil, they give equal pressure on both sides.
Mhm.
Okay. I feel you should not use the ribbon gauze. ribbon gauze is not a good idea, because you cannot give proper equal pressure on either side. I
Yes.
feel better
Yes.
to go for nasal packs for rhinoplasty.
Yeah.
Some surgeons use ribbon gauze. I don't
Mhm.
feel it is a good idea. Okay,
Yeah.
then half-inch needles, 1.5-inch needles, 2 ml syringe, all those things are important. You must keep ready well in advance. Okay, this is all ideal situation. What I'm talking now, preoperative preparation, most of
Mhm.
the time it is not possible. Ideally, it is better to go for surgery early in the morning, because sometimes it will take 4 hours, 5 hours to go for a surgery, do surgery. You may lose your OPD patients if you do it in the afternoon or in the late morning. Why to lose your OPD patients? Do it early
Yes.
in the
Yes.
morning
Yes.
and admit the patient well advance before
Yes.
night only. I feel it is important, because I have seen, I have
Mhm.
waited for the patient for 2 hours, 3 hours in the early in the morning. So I
Yeah.
feel it is
Yeah.
better to admit the patient well in advance.
Yeah. Very
And
important point.
anesthesia, yeah, anesthesia, it depends on the deformity. If the minor deformity, you can do it in local anesthesia. If it
Mm.
is a crooked nose, you need extra dissection, extensive surgery, then go for general anesthesia. So
Mhm.
these are the things you must understand well in advance.
Yeah.
Okay, the instrument, cautery, suction, everything should be ready.
Yeah.
So should, and all those things are antibiotic solutions, infiltrations, all those things. All the staff should keep it ready. And if
Mhm.
possible, train your staffs, assistants, nursing staff, surgical trolley, everything should be ready. So if
Mhm.
your assistants are good, again, this is it's an asset for you. They will help you to finish the surgery fast, and it will be good for assistants also. They will learn more.
Yeah.
Okay. But so what kind of exposure, like what kind of incisions you want to go for it? It all
Mhm.
depends on the deformity. There are different incisions, like intranasal incisions, external incisions, approach, external approach, sublabial approach. It all depends on the deformity. Sometimes
Yes.
patient will have a nasal dermoid cyst, the whole opening in the nasal dorsum. In such conditions, the incision will be on the dorsum of the nose. Okay, so there's no need to go for intranasal approach or external approach, columnar incision. All those things not required. Sometimes you may have to go sublabial approach if the deformity is on the maxilla. Okay, it all depends on
Yes.
the deformity. Okay, so I'll go to the one more point I want to add here. You must tell the anesthetist. Anesthetist is important team member in your surgery.
Yes. Yes.
You must tell the anesthetist to have South Pole tube, South Pole RAE tube.
Yes.
South Pole tube
Yes.
will be like U-shaped tube. It will
Yes.
not come in the way when you operate. So the tube will go towards the foot end. Like
Yes.
it will not come in the way when you do the procedure. So
Yes.
always go for South Pole RAE tube. And
Yes.
throat pack, proper throat pack is required. And tell the anesthetist to go for smooth recovery.
Yeah.
You request the anesthetist to give smooth recovery, so that there will not be any facial grimace.
Mhm.
When the facial grimace or facial movement, the splint will displace, and
Mm.
that will land up in failure.
Important point. Yes. Yes.
Okay,
Okay.
so all those things are important. So, and the position of the patient, the head end should be in a higher position,
Mhm.
and it is like reverse Trendelenburg position.
Okay.
Okay, the foot end will be in the lower side.
Mhm.
So this position will help you to reduce the bleeding.
Okay.
Okay,
Mhm.
this is how the position of the tube. See, the
Yeah.
position of the tube, it should be in the midline, and it will not displace, or it will not disturb the natural anatomy.
Yes.
Okay, most of
Yes.
the time I've seen anesthetist will put the tube on the angle of the mouth.
Yes. Yes.
When the angle of the mouth is stretched, the nose also will stretch, and
Yes.
it will be a you may not sometimes it will be a disaster. You feel it is a
Yes.
deviated one, and you will correct it.
Yeah. Yeah. That uniform symmetry should be there.
Yes, sir.
Very important.
And you must take care of the eye because you have to use eye ointment like Ciplox D ointment or some Neosporin H ointment,
Mhm.
and cover the eyes with a 1-inch plaster
Yes.
like this. You have to cover entire eye, and you must cut the plaster in
Mm.
diamond shape medially,
Mhm.
so that the entire nose is exposed,
Mhm.
but the eyes are covered. Okay, so
Okay.
the by doing this, you will be safe. The eyes are safe, and you can do whatever procedure you want. You can do it. Sometimes the anesthetist will put the gauze pieces. It's not a
Mhm.
good idea. Don't go for gauze pieces. Keep
Yes.
only
Yes.
the plaster.
Yeah.
Okay. Okay. The approach. There are different approaches, as I said earlier.
Yeah.
You can it can be a closed approach or open approach. It all depends on the deformity and the training what you have. According to me, closed approach is a difficult one. It needs
Yeah.
more training, and it needs a lot of perception. You must imagine and do. I
Yeah.
feel
Yeah.
open approach is easier than closed approach.
Yes.
Okay.
Agree with you.
Yes, sir. And then incision. There are different incisions. There are intranasal incisions like intercartilaginous incisions, transcartilaginous incision, marginal incision. These are all incisions depending upon the deformity. If the deformity is only in the bony framework, then I think you can go intercartilaginous incision and just go and do the humpectomy or some bypass the tip by doing intercartilaginous incision.
Yeah.
The external approach, transcolumnar incisions, marginal incisions are essential, and by doing that you can elevate the flap depending upon the deformity. If you want to do only tiplasty, the flap elevation will be up to the
Mhm.
keystone area.
Yes.
Okay, if you want to do something like humpectomy or some augmentation, then you have to elevate the flap up to the ranion, up to the frontonasal junction.
Yes.
So this is a picture showing uh, incision lines. These are dotted lines showing incision. There are different types of columnar incisions.
Mhm.
This is a inverted V columnar. This is a standard one, inverted V columnar incision, and vertical columnar incision. This is a marginal incision. By doing
Okay.
this on either side, you can elevate the flap. In some conditions, you can do a step incisions. There is something called step incision for columnar incision.
Mhm.
Some surgeons use it, and sometimes you have to do sublabial incision. Sometimes you have to do nasolabial incisions in
Mhm.
cleft lip, cleft nose patients.
Yes.
So in such cases, you have to give incision at the junction of lip and the nose. Okay, this is the picture showing inverted V columnar incision. I use methylene blue, and I use sometimes I use sharp scissor or toothpick. This is a picture showing dorsal incisions.
Mhm.
I said earlier, this is a nasal dermoid sinus cyst.
Mhm.
There is a dot here. Can you see here the dot there?
Yeah.
So
Yeah.
in
Yeah.
such
Yeah.
conditions, you have to give incision over the nose and
Yes.
then excise it. Okay, this picture showing flap elevation.
Yeah.
Okay. This is up to the nasion. If you want to go for humpectomy, you can elevate the flap up to the junction of the forehead and the nose.
Yeah.
Okay, use the sharp scissor to elevate, and the flap is supraperichondrial plane over the cartilage. It should
Yeah.
be supraperichondrial. That is the avascular plane.
Yes.
Okay, when you go over the nose, over the bony fragment, bony framework, you have to go subperiosteally. Subperiosteal plane, it's a avascular plane. If you injure the periosteum, you will land up in bleeding, a lot of
Yes.
bleeding,
Yes. Yes.
and it will not give good results. Even after surgery also, the patient will have a lot of post-operative edema. Okay. Okay, dorsal modifications. If the patient is having something like hump, we have to shave off the cartilage. We have to remove the bony part by doing rasp or humpectomy osteotomes. If the patient is having saddle nose, then you can use the various materials for the augmentation. So most of the time,
Important, yeah.
if the minor correction, we do septal cartilage, or sometimes we may require conchal cartilage, rib cartilage. If the patient is having severe saddle nose, more than 4 to 5 millimeters, or some people use bone graft, but I don't recommend bone graft because the bone will resolve. It will disappear.
Yeah.
Okay. Some patients I have seen using dermofat, the dermofat from the buttock area.
Mhm.
Then alloplast. There are different alloplasts available in the market. They are like Gore-Tex, Medcore, all those things are there. So
Yeah.
this is a picture showing humpectomy marking. This is how when you do operate, you see this is how you mark it and you excise it with the number 11 blade. So this is a picture showing humpectomy.
Okay.
Earlier, the in the beginning, when you do humpectomy, first I cut the cartilaginous part with the
Yes.
blade, and then I use humpectomy osteotomy.
Okay. Okay.
After that, I go for septal cartilage harvesting. Whenever I harvest the septal cartilage, I harvest in one piece. I will try to harvest in one piece so that it will be easy for me to carve it and use it for different reconstruction techniques like spreader graft, columnar strut, caudal strut, cap graft, all those things.
Important point. Yes.
Yes,
Yeah.
sir. Then comes the osteotomies. After harvesting the cartilage, we'll go to the osteotomies. First, I do medial osteotomy and then lateral osteotomy. If the patient is having gross bony deviation, then we have to do transverse osteotomy. I'll
Okay.
show how to do it. See, this is the picture showing humpectomy. This is the medial osteotomy line, and this is the lateral osteotomy line.
Okay.
Sometimes the patient, if the lateral wall of the nose is more than 5 centimeter, then you have to do intermediate osteotomy.
Okay.
Yes, sir. I have
Important,
on my I have one article. I have written one article on intermediate osteotomy.
Okay.
I will give the link later.
Yeah. Yeah. You should share that. Yeah.
Okay. This is the line showing. This is the marking showing transverse osteotomy. This line is medial on the left side, on the right
Yeah.
side. If you do it, if you take osteotomy and cut the bone here, you will move the entire nasal framework in one unit.
Yes.
Okay. And then sometimes I use fingers instead of osteotomes. I use fingers to give minor fractures, minimal fractures. Sometimes the bone will not be fractured properly. Then with the finger you can give fractures.
Yeah. Yeah.
There are various osteotomies. There are instruments very essential for crooked nose surgery. You have to go for external osteotomes. These are the external osteotomes. This is 2 millimeter, 3 millimeter, and then humpectomy osteotomes. These are the internal osteotomes. There are different. The company have different kinds of osteotomes. You can get it in the market. Then speculums and all those things are important. RASP.
Yeah. Yeah.
RASP is also important. If you want to do only minimal RASP, minimal humpectomy, RASP will.
Yeah. Having a good collection of instruments is very important.
Yes, sir.
We may not get it at one source. We'll have to source it from different places, right?
Yes, sir.
Yeah. Yeah. Yeah.
And this is the picture showing transverse, the percutaneous osteotomy.
Yeah.
You can use number 11 blade or 15 blade, and you can give incision, the punch incision, like and stab incision, and then you can use osteotome.
Yeah.
Okay, this is how I do internal osteotomy. This is all marking transverse osteotomy on either side.
Yeah.
And this is a picture showing spreader graft. After osteotomies, the next is the middle 1/3 of the nose. The osteotomies will take care of the upper 1/3 of the nose.
Yeah.
There is a deformity in the upper 1/3, that is bony fragment, bony framework. You have to do osteotomies. After that, middle 1/3, if there is any deformity, you can use spreader graft. The lower 1/3 is tipplasty. Nose is the tip of the nose is the lower 1/3. So like this, you have to divide the nose into 3 parts and address the nose in like 1/3, 1/3, 1/3, like upper 1/3, middle 1/3, and lower 1/3, and then finish the surgery.
Very important. Yeah.
Okay, this is the picture showing the harvested cartilage. I have kept it as a caudal strut. I have kept this on the anterior nasal spine, ANS.
Yes.
I have sutured it to the anterior nasal spine and the dorsal strut.
Okay.
There is something called 2-point fixation of the septoplasty. 2-point fixation of septoplasty is important point. You must know. You have to fix the septum superiorly and inferiorly. Superiorly, it will be attached to the keystone area. Okay. The only thing is when there is a caudal dislocation, when there is a cross deformity, you will remove the cartilage inferiorly. You will remove a strip of cartilage or the excessive cartilage inferiorly. Then the cartilage will be wobbling. It will be moving. So in such conditions, it is not fixed. So patient will have a tip drooping. Tip drooping, and patient will have some deformity in the tip, nose block because of the tip drooping. So to avoid such things, there's something called 2-point fixation. You have to fix the septum to the anterior nasal spine. Then it will fix the septum in the midline. Okay, next comes the columnar strut. You can keep the strut in between the medial crura, and then it gives stability to the nasal tip. Okay, after that, there are different sutures. There are different suturings like transdermal, interdermal, lateral pleural. There are different suture techniques for tipplasty. So some other time we will discuss only the tipplasty. So
Yes, certainly, certainly.
Topic.
Yeah. We'll definitely have another event sometime in the future on tipplasty also. Sure. Okay.
And then the different grafts are there. The columnar strut, shield graft, cap graft. All these grafts are helpful to define the nasal tip. Okay. And then the different lateral pleural strut, alar batten graft, lateral pleural graft, rim graft. All those things will help to define the lateral pleura, the ala of the nasal rim.
Yes.
So this is again, I said the tipplasty and grafts. It's an extensive topic.
Yes, I agree with you. Yeah.
Dorsal modifications. See, I told you there are different materials for dorsal augmentation. Homograft or like septal cartilage, we can harvest and we can keep it. That's the safest one.
Yes.
If there is not enough cartilage, then you can harvest from the concha, from the ear pinna. But the only problem is it's a painful procedure, and there's one more incision, one more procedure. So if the patient is not willing for that, if they are not given consent, then don't go for it.
Yes.
Don't just directly jump and open the concha and do it if the patient have not given consent.
Yes. So we have to obtain a separate consent for each.
Yes, sir. Rib cartilage.
Yeah.
Cartilage.
Very important point. Yeah.
Rib cartilage is again is one more procedure. I feel rib cartilage harvesting is again one more topic. We will discuss some other time. Then you go for the alloplast. Alloplasts are the materials like Gore-Tex, silicone, Medpore. There are a lot of things available in the market. Gore-Tex is available, silicone, Medpore are all available, but I don't recommend. I don't go for it unless patient is not willing for rib cartilage, conchal cartilage. If the patient wants artificial material only, then only I go with the Medpore. I don't go for silicone. Silicone, after 10 years, 15 years, it will come out. It will come out, or it will lead to calcification.
Yes.
Lead to calcification and a lot of problems with the silicone. I have seen patients with silicone. This is the Gore-Tex. This is our professor used to use Gore-Tex. It has its own advantages, disadvantages. And then coming to the closure. Closure of the incisions. There are different materials I use it. So I use 50 Vicryl for the marginal incision that is given inside the nose. 50 Prolin for columnar incisions. 50 PDS for cartilage suturing. Cartilage suturing must be done by 50. Don't use any other things. It may lead to infection and land up in deformity, residual deformity.
Okay.
And 30 Prolin for internal nasal splint suturing. The nasal packing, I use nasal packs,
Can we go
mucosa
back
or
to this
nasal.
previous slide? Can you go back to previous slide?
Yes, sir.
Yeah.
Yes, sir.
Yeah, this slide, I think I encourage all junior colleagues to take a snapshot of this slide. A very important point made, sometimes, we Indians trying to be economical, try to finish the whole thing in one suture. With a different
No,
suture
no,
material.
no, no. Should
Yeah.
not be economical.
Yes. This is a cosmetic surgery. We are
Yes.
doing a specialized surgery, and each individual entity requires different suture material. Very important point. Another important point, Chidanand, this I love this slide. Yeah, go ahead.
The nasal packing.
Yeah.
I go for nasal pack. I pack all the patients. Sometimes we do endoscopic sinus surgery. We do some septoplasty.
Mhm,
Some surgeons, they don't like packing nowadays
mhm,
because there's no bleeding. Why to put pack?
mhm,
But in my opinion,
mhm,
you have done something like septoplasty, some bony fractures,
mhm,
osteotomies. It is better to pack the nose from
mhm,
inside, and from outside we keep the splint.
mhm,
So by doing that,
mhm,
hematoma will be less. Like the chances of hematoma will be
mhm,
less.
mhm.
Otherwise, the nose, you have elevated the flap, the entire nose will become swollen,
Yes.
and that will lead to again deformity, the residual
Mhm,
deformity or something like that. And if you
mhm,
have done only tip plasty, then
mhm.
no need to pack the nose, entire nose nasal cavity, no need to pack up to the nasopharynx.
Yeah.
You just take a 5 centimeter pack and just keep it just in the tip
Yeah.
area.
Yeah.
Okay, you can customize the packing depending
Mhm,
upon the patient.
yeah.
Okay, I will on, then I do a packing like this.
Yes.
And I use glove paper. Earlier, I used to use glove paper. Now I use ribbon, the gauze piece. You can take just a gauze piece or
Mhm,
steri strip. You can use steri strips. That
mhm.
depends on the training, whatever training you have done, like coding.
Yes.
All depends on you.
Yeah, this is one thing, one area I've noticed when we put this glove paper or steri strip, all these the sweat glands, become kind of hypertrophic, and nose looks very dotty.
Yes,
It happens with the most patients.
yes, sir. You are right.
Yeah.
The skin will become dark, and
Hmm.
it looks like sometimes some kind of hyperpigmented
Yes.
uh, skin lesion
Yeah.
kind of a
Yeah.
thing.
Yeah. Yeah. But that will
Uh,
subside with course of time, right?
yeah, it will disappear after a few weeks.
Yeah.
Okay, and this is how I put the plaster. I take half-inch plaster and cover entire skin of the nose.
Hmm.
I will just leave the tip of the nose. I will just leave this part of the nose to know the vascularity of the nasal flap.
Yeah. Very important point. Fantastic.
And I use nasal splints, external nasal splint.
Yeah.
Okay, I just give a little bend on the nasal at the corners of the nasal splint. This is to
Hmm.
avoid extra pressure over the nasal skin. Sometimes patient
Yeah.
will tell there's some pain over the nose. This
Hmm.
is because of the sharp edges.
Hmm.
These are my small things I just wanted to share with you.
No, these are important points. This is what junior colleagues have to learn. I think you emphasized these points rightly.
Can you see
Uh,
the little bend here, sir?
yes. This I wanted to ask you, what is that? Yeah.
Okay,
Mhm.
so this is how I do dressing.
Yes.
I use plasters and aluminum splint. I don't use
Yeah.
POP. I don't use plaster of Paris.
Yeah.
Where it's not tidy. Some
Yes.
problem with
Yes.
the
Yes.
POP. Post-operative care. Well, coming to the post-operative care, you tell the patient not to disturb the nasal splint,
Mm-hmm.
and even you have to tell the patient for the nursing staffs, whoever
Mm-hmm.
take care of the patient, they will keep the nasal mask over the oxygen mask over the nasal splint.
Mm-hmm.
So that will displace the nasal splint.
Mm-hmm.
So what I do, I will reverse the oxygen mask, and it will sit on the forehead and the chin like this.
Mm-hmm.
So
Mm-hmm.
that will avoid the disturbance or the pain over the nose. And
Okay.
the patient should have head end elevation, 30-degree head end elevation, to avoid periorbital ecchymosis edema.
Yes.
You can use ice compress, steroids.
Mm-hmm.
I use 4 mg dexamethasone, IV
Mm-hmm.
antibiotics,
Mm-hmm.
and I remove the pack after 48 hours. hours if I have done osteotomies. If I have done only Rhinoplasty, then I will remove the pack next day only.
Yes.
Okay, then the nasal splints I remove on the 10th day. Sutures, nasal splints, internal splint, external splint, everything I remove on the 10th day. And I do regular follow-up like once in 2 weeks, once in 1 month, like 3 months, 6 months, every year. And after that, every year you have to ask the patient to come and don't charge them. You should not charge the patient when they come for follow-up.
Yes. Yes.
Okay. Then only they will come back again and again. Otherwise, they will not come.
Yes, important. Important. Yeah.
And then this is all. Then it's coming to the complications. These are the complications. I don't say they are common, but if you are not properly done the procedure, if you are not properly sutured it, and if you are not hemostasis done hemostasis or septal abscess, if the patient is not taken in medication properly, they may land up in abscess, infection, septal abscess.
Yes.
Sometimes what happens, the patient will have a residual septal deviation.
Yes.
There they will land up in nasal obstruction.
Yeah. Yeah.
After surgery, patient may land up in nasal obstruction.
Yes.
Sometimes the spreader graft will displace downwards and they will land up in nasal obstruction. And
Yes.
if you have not sutured the caudal strut to the anterior nasal spine, then also you will land up in nasal obstruction.
Yes. Yes.
Okay, then saddle nose or polybic deformity, depending upon the if the patient nasal septum or the cartilage is necrosed, then you will land up in saddle nose. And I've seen paresthesia over the tip. When you do a transverse columnar incision, when you do a inverted V columnar incision, you will cut the columnar nerves, columnar nerve fibers. So they will have a kind of a paresthesia. Whenever they touch the nose, they feel some annoying kind of a sensation.
Yes.
So that will disappear after a few months, like 3 months.
Yeah. Important.
Okay, then residual deviation deformity will be there. If the then you can tell the patient to go for one more revision surgery if they want.
Yeah.
Okay, this is the chronology of the procedure. You must know what comes first and what comes next.
Yeah.
So
very important. I mean, this is another
this
important slide. I asked junior colleagues to take a snapshot and keep it. The syntax, the test steps of the procedure is a very important point. Yeah,
Yes.
go ahead.
So you have to protect the eyes, hairs, and draping, infiltration, next marking, then incision, then flap elevation, dorsal reduction. If you want to go for humpectomy, you can do it. Then only. Don't go for osteotomies and then do dorsal reduction. It is difficult.
Yes.
Okay. Then cartilage harvest. You have to harvest the cartilage, and then septal deviation correction. Then go for osteotomies. So osteotomies comes after septal cartilage harvesting. Okay.
Yeah.
And then spreader graft. See, you cannot keep spreader graft before osteotomies. If you keep spreader graft and then do osteotomies, the spreader grafts will displace.
Yes.
Okay. So like that, you have to. It should be in an order. If you want to do something, you have to do it in an order. Then columnar strut, Rhinoplasty. In dorsal augmentation, if you want to do saddle nose deformity, first you have to do Rhinoplasty. Then you will come to know what is the exact deformity, what is the amount of cartilage you must keep.
Yes.
And then suturing, then alar reduction. Alar, sometimes the alar width will be more. You can do it at the end, or you can do it in the second sitting or third sitting. The alar reduction is entirely a different, again, it's a different topic. We can discuss later. And then nasal packing, dressing, and aftercare and follow-up. This is how it should be.
Yes.
Okay.
Important. Yeah. Good.
These are the few pictures I have done before and after surgeries. This is a saddle nose deformity. I've corrected by doing by using septal cartilage.
Yes.
This is a septal cartilage. I have used septal cartilage for augmentation, and I have used Medpor for this patient for augmentation. And this is again septal cartilage. I have used septal cartilage for augmentation.
Yeah.
And this is for this is again the septal cartilage.
Mhm.
In this patient, again augmentation. Here in this patient, there is a dip after the keystone area.
Mhm.
So here I've used spreader graft and columnar strut to make the nose straight.
Mm.
Okay, this is again I've used conchal cartilage for this. Only the small depression here. I've used it. Okay, this is one. Again, this patient, I did it in Davangere, I feel. I did it with the conchal cartilage. I used conchal cartilage. This patient refused for rib cartilage harvesting. She was not
Okay.
ready to, some kind of a shy kind of a patient. She don't wanted to show some chest or some kind of, I don't know. I used conchal cartilage and she was happy with the result.
Mhm.
Okay. And this is a pediatric septoplasty. I did closed reduction by doing internal osteotomies. I did internal osteotomies, and patient is happy with the. I did not do any incisions in the columella, flap elevation, nothing. Just I did osteotomies, and patient is happy.
Oh, great.
And
Yeah.
this one more case. One more case. And this patient, crooked nose, I did osteotomies, transverse osteotomies on either side.
Okay. So
Like
you
this.
also take a consent, to use their pictures in presentations and all.
Hello, sir.
Yeah. Do you take consent for using their pictures in the presentations?
Yes, yes, we have
Yeah.
to take consent.
Yes, yes. Very important.
Very, very important. That's what I said in the preparation part.
Yes, yes.
We have to take consent for publicity or public
Yes.
display.
Yeah, 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 yeah.
So I'm concluding now. The basis for doctor-patient communication in aesthetic surgery must be openness and honesty on both sides.
Yeah.
On both sides, honesty is
Yes.
important.
Yes.
We must honestly convey to the patient what can be done and what is unrealistic and impossible.
Yeah. Very important. Yeah.
This is the best way to correct the false expectations, preconceptions, and avoid failures.
Yeah.
Okay. The last slide. Good results do not build a practice, but happy patients do.
Yeah, that's another profound statement, Dr. Chidanand.
Yes.
Friends, stay back. There is a video also followed by this. I mean, some of them are maybe thinking that presentation is over. Please stay
Oh,
back.
sorry, sir. I should have not told the last
Yeah,
slide.
it's a conclusion. It's okay. No problem.
Okay.
Yeah.
The one video is there.
Yeah, video is
If
there.
you
Video
time
presentation.
permits, I will show, sir.
No, you should show it.
Yes, sir.
Yeah, we can extend meeting for a few more minutes. Yeah, no problem. Yeah. Go. Now we can stop sharing this presentation. Go to the video.
Okay, sir.
Yeah, you should share that video application. Yeah. Yeah. Before, can you? Yeah,
Yes,
go ahead.
sir.
Go ahead. Yeah.
This
Can you
is
pause
a
it?
video. This is a video I have.
Yeah. Can you pause it? This thing for a second. Yeah.
Pause, sir.
Pause it for a second.
Yes, sir. Yes. Sir.
Yeah. Okay. Yeah. Before we go for that, there are a couple of questions. We'll do it. Okay.
Okay.
Yeah. Okay. Dr. Rachel Kezia, I don't know from where. Asking, do you use magnifying loop while you operating?
Yes, sir. I use a 1.6 magnifying loop.
Yes, sir. You use
I
a
use
Kim's
a Kim
headlight
headlight.
or Kim's headlight?
Kim
Yeah,
headlight.
fantastic.
Yes.
Yeah. Okay. Anyway, Dr. Victor from Rwanda, Africa, is asking, can you describe in details how do you do local infiltration, which you are going to show anyway now. And and one more question, what type, Dr. Anandita from Assam, she's asking, what type of osteotomies are needed to reduce a broad bony base of nose?
Broad base of the nose. Yeah. We have to do internal osteotomies. We have to use a strong osteotomes.
Yeah.
We have to do internal medial osteotome and then lateral osteotome and then push it down.
Okay. Yeah. Go ahead. Yeah.
Okay. So this is the fast forward. I have the video is fast because we have edited it because it will take a lot of time to show the video.
Yeah.
the fast forward video.
Yes.
This is how I give infiltration. This is I use a 26 gauge 26 gauge 1.5 inch needle.
Long needle, yeah.
Long needle. I give infiltration to the nasal dorsum and then to the lateral wall. I will give infiltration to the lateral wall now.
Yes, yes.
Okay. See, I use a Killian's retractor and I go just close to the bone and give infiltration like this.
Yeah.
Okay. And then give infiltration to the nasal septum. In nasal septum also give infiltration, proper infiltration for hydrodissection.
Yeah.
It is easy to elevate the mucoperichondral flap if you give a proper infiltration entire nasal septum. Okay, and then I give infiltration to the turbinates also.
Yeah.
Okay. Sometimes if the turbinate size is more, I do out fracturing. I don't resect. I don't do turbinectomy. I just push that cartilage laterally.
Yeah, yeah.
Okay, after incision, I use a sharp scissor to elevate the flap over the medial pleura. I use a small pediatric cautery tip to cautery the columnar vessels.
Yeah.
And then now I'm using a sharp scissor and I'm just close to the dome and alar cartilage. I'm going in the subperiosteal plane, supraperiosteal plane.
Yeah, yeah, yeah. Could you pause for a second? Yeah.
Yes, sir. Supraperichondral plane.
Yeah, yeah. So this question from Dr. Dhruv Kapoor. What was the concentration you used for infiltration?
Infiltration, I use 2% xylocaine with adrenaline, 1 in 2 lakhs.
Okay, okay.
And I dilute it. I dilute it 10 ml, 2% xylocaine with adrenaline, 10 ml saline.
Okay.
It will become 20 ml.
Yeah, yeah, yeah. It becomes 1 in 4 lakh in that case.
1 in 4 lakhs.
Yeah, yeah.
So the main thing is you have to go in a proper plane, avascular plane.
Yes, yes.
The infiltration, I give it for hydrodissection.
Yes, very important point. You stress upon. Yeah, yeah, yeah.
Okay.
Yeah.
Next, shall I continue?
Good, good. Yeah.
So after a flap elevation over the nasal tip and the alar cartilage, the assistant will retract the flap superiorly. Now I am cutting the attachments over the upper lateral cartilage.
Yeah, yeah.
Upper lateral cartilage attachment. Slowly, 5 by 5, you have to cut the cartilage attachments. And the plane should be supraperichondrial plane.
Yes.
Up to the upper lateral cartilage.
Yes, yes.
After that, see, I'm using a Freer's elevator to give incision over the periosteum. I will go subperiosteal plane. After giving incision to the nasal bone periosteum, I go subperiosteal plane and I elevate the flap up to the rhinion, up to the junction of forehead and nose. This is how I elevate. I just by to and fro motion, that will go, and I keep the I use adrenaline soaked gauze piece, and now I'm doing septal exposure. Now this is the anterior septal angle. So you can see here that is a projected part. That is the anterior most part of the nasal septum.
Yeah, yeah.
Okay. Now I using with the sharp scissor, I cut the perichondrium and I deflect it. Okay, so this is how I go to the avascular plane and I use a suction elevator. I use suction elevator to dissect, to go posteriorly and superiorly. So in one go, I will just elevate entire mucoperichondrial flap on the one side, and I'll repeat it on the other side. Now, now I'm repeating on the other side now.
Yeah, yeah.
I'm using sharp curved scissor, and with the scissor only I will cut the chondrium.
Okay. Okay.
And I cut the upper lateral cartilage also.
Okay.
Okay, now I use a suction elevator, and elevating the flap.
Yeah. Yeah. So elevate on both sides.
I elevate on the
Mucopericardial
both
flap.
sides.
Yeah.
I elevate on the both sides. This
Mhm.
is one more important thing I want to know. I want to share with you.
Mhm.
If you elevate flap on either side, the
Yeah.
fibrosis will be symmetrical.
Symmetrical. Important point. Yes. Yes.
If you elevate only one side,
Mhm.
nose will shrink on the other side. It will
Mhm.
pull the nose.
Mhm.
So this is important. And now I have harvested the septal cartilage,
Mhm.
and I am removing the bony deformity,
Mhm.
bony deformities, deviations, and spur.
Mhm.
Then I extend the dissection now. I am extending the dissection laterally over the
Mhm.
alar cartilage.
Mhm.
And I'm just now looking at the skin. Now the skin is thick.
Mhm.
The areolar, loose areolar tissue is more. It's more. So I'm just excising it. Now I'm doing cephalic resections of the upper
Yes.
the alar cartilage.
Mhm.
On the other side, I'm doing now. So this is the alar cephalic resection. I'm using
Yes.
number 11 blade,
Mhm.
and I'm cutting the cephalic part of the alar cartilage.
Yeah. Yeah.
This will avoid. This will help to give a sharp tip. Now I'm planning
Yes.
for the osteotomy.
Yeah. Yeah.
So I use methylene blue or marking pen. You can use marking pen also. Ramson's marking pen. Okay. Now I'm cutting the upper lateral cartilage up to the bony margin. Okay, I'm doing medial osteotomies. After medial osteotomy, I do lateral osteotomies.
Yeah. Okay.
Okay.
Yeah.
So this is how I do. First, I give incision. This is an internal lateral osteotomy. I give
Okay.
number 11 blade. I give incision just above the anterior end of inferior turbinate,
Yeah.
and
Yeah.
I use lateral osteotome.
Mhm.
Okay, I just see that's how I introduce the lateral osteotome, and I do osteotomies.
Yes.
Similarly, on the other side, I did give incision and go to the periform aperture and do the osteotomies.
Mhm.
Okay, the hand is coming in the way.
Mhm.
Okay, and then I do after that I do a tipplasty, and then I go to alar reduction.
Mhm.
This is in this picture, in this surgery, I've done alar reduction. So this patient had a broad alar base.
Yes. Yes.
Broad alar base. So she wanted to have a narrow alar base.
Mhm.
I have given incision as shown in the mark. I have marking done.
Mhm.
See, I am removing the loose areolar tissue over the nasal tip area. I'm using a blunt scissor. I'm removing the loose areolar tissue. This is a very risky procedure. Beginners, please don't do it because sometimes you will cut the nasal, skin over the tip. Only the loose areolar tissue you should cut it, and you have to stop at the white. When you look at the white color change, when there is a white, you get a superficial fascia, then you have to stop at that.
Okay. Okay. Important. Yeah. Yeah.
When there is a color change from red to the white, then you stop it.
Yeah. Yeah. So you're going to do the defatting.
Defatting, yeah.
Yes.
Defat.
Okay.
So this will help to
You
give
do
a
it
sharp
in the
tip.
all cases?
Not all cases. Only when there is a patient want a sharp tip and
Yes. Yes.
skin is
Yes.
thick, then
It
only
gives
you
a
have to
good
give.
this thing into the architecture. Good
Yes,
draping over the architecture.
yes, sir.
Yeah. Yeah.
This is a spreader graft. I'm keeping the spreader graft.
Yeah. Yeah.
So actually this in this video, I'm going back again to the surgery.
Yes.
Actually, other reduction I've already shown you, but
Yeah.
this is a spreader graft suturing.
Mhm.
I use a half-inch needle to keep the spreader graft in place.
Yes, yes.
And I take a 450 PDS to suture it.
Yeah, yeah.
So this is how I suture it. Most of the time I use only one side spreader graft. If there is a deviation, C-shaped deviation, I will keep the spreader graft to the concave side.
Concave side, yes,
Concave
important
side.
point. Yeah.
That will make the nose straight. Okay, in this case, the patient wanted a tip, sharp tip. That's why what I did, I sutured extended spreader graft. Extended spreader graft will go up to the nasal tip. Can you see here? This is a dome. This is the dome.
Yeah.
The spreader graft is coming out of the dome.
Yes.
So this will give a sharp tip. It will give good definition to the nasal tip.
Yeah. It's projecting outside a little bit. Yeah. We can make out. Yeah. How many millimeters it can project out like that?
No. It will at the end we have to, if it is, it should
Too much,
be in line with the. It should be in line with the medial crura.
Yes, important point. Yeah.
If it comes out, then it is difficult. The patient will end up in all the paresthesia, all those things. I'm exposing anterior nasal spine here.
Okay.
Now I'm exposing anterior nasal spine, and then I take cartilage and keep. I take a bite from the periosteum around the anterior nasal spine, and then fix the cartilage to the extended spreader graft. Okay, and then now I am suturing the skin. So spreader graft and the caudal strut I have sutured, and now I am suturing the skin. I'm using 50 prolin. 50 prolin for skin suturing. The tip, can you see here the caudal strut and the extended spreader graft? Now I am keeping the cap graft.
What graft is that?
Cap graft. Cap
graft.
Just
Yeah,
like
cap graft. Yeah, it's like cap.
The patient wanted sharp tip. So I take a septal cartilage and I just keep over the dome in between the medial crura and the lateral crura.
Okay.
Okay, I take 50 PDS and suture it.
Okay.
This will define the nasal tip. It will give good aesthetics to the nasal tip.
Yes, very important point.
Tip defining points and all those things. You can see the light reflex when you close the nose. It will increase the sharpness of the nasal tip.
Yes.
So when you drape the skin, you will come to know whether patient require extra height, extra cap graft, anything like that. Then you can modify your techniques and you can keep the graft if you want. Otherwise, you can just leave it like that.
Yeah.
Okay. So after that, I suture the columnar incision with the 50 prolin.
Yes.
Sometimes some surgeons use 60 also. 60
Okay.
prolin.
Okay.
But it is sometimes it will cut and it will
it is
difficult.
Difficult. Right.
So it is a repetition, I think. It's a repetition.
Yeah.
Ala reduction.
Ala reduction, part. Yeah. And that also you suture with 50 prolin.
50, sir. I use 50 prolin.
Yes.
So a lot of beading will be there. Just cautery. You have to use the cautery.
Yes.
And then I use 50 to suture it. Suturing is important here. The approximation should be 100%. Should be in the same line. Otherwise, you will have a notching. Kind of deformity.
Yes.
And it looks artificial. So suturing should be perfect. It should be it should look natural. And most of the time, the nasal orifices will not be symmetrical after doing alar reduction. Even our professor used to tell, even God cannot give symmetrical nostrils.
Yes, yes.
So
That's very
nostrils,
important.
there will be minimal changes will be there.
Yeah.
You must explain to the patient well in advance before surgery only. You must explain.
Okay. Very important point. Yeah. Friends, if you have any questions, please raise your hands or post in the group. I mean, in chat area. Yeah. Please feel free to ask questions. We had a wonderful presentation as a demonstration by Dr. Chidanand, and please.
How is the quality, sir? Quality of the video?
The video is good. Fair enough. Yeah, it's a recorded video.
Recorded video.
Yeah. It's a fair enough. This thing.
It's a fast forward video, sir. Like we.
Yeah. It's okay. No problem. Yeah.
And now I'm suturing. So this is that's it, sir. We. It's over.
Yeah. Great. That was great presentation. Great insight. Great philosophy. Motivational also for many junior colleagues. Really fantastic job you've done, Dr. Chidanand. I'm so happy. I'm so proud of you. Yeah, friends, please raise your hands if you have any questions. Please feel free to ask the questions. This thing at this stage, anyway, Dr. Chidanand, you demonstrated so well. I think there's hardly any scope for questions, but still, you may have a doubt. And Dr. Dhruv Kumar again is asking the concentration of adrenaline used for infiltration. You have told that already. That is, you are using ready mixture. That is 2% Zolocaine with 1 in 2 lakh adrenaline. You're diluting with 10 ml of saline, 10:10. That means that makes 1 in 4 lakh adrenaline, right?
1 in 4 lakh.
Yeah, 1 in 4 lakh. That he has told already, Dr. Dhruv Kumar, sir. Dhruv Kapoor, sorry. Any other questions, friends? Yeah, there is who is Dr. Anandita? She wants to ask, ma'am. You can unmute yourself. Yeah.
Good evening, sir. Thank you for such a wonderful presentation. We really enjoyed it. My question is that if there is no septal cartilage and we have to put in a rib cartilage as a L strut, would you prefer to use one piece as a L strut or two different pieces joined together?
It is better to use two pieces. It is better to use two pieces. L strut, there's something called warping. You know warping, I think.
Yes.
You know about warping. So over a period of time, maybe after 5 years, maybe 10 years, the patient may get deviation due to warping.
Okay.
So it is better to harvest the rib cartilage, take the center part of the rib cartilage.
Right.
Don't use the cortex part.
Right.
The core part.
Yes.
And then you just leave it for 30 minutes. You harvest the cartilage, cut it, and keep it in the saline for 30 minutes.
Okay.
You will come to know the status of the cartilage, the warping, and the deformities. Usually the cartilage will deviate. It will take its own shape after 30 minutes. Okay, then you take a straight one. You take a straight part of the core cartilage and use two pieces and suture it.
Right.
So it is better to take a core part of the rib cartilage and then wait for 30 minutes, keep it in the saline, you wait for warping on table, and then you take a straight part of the rib cartilage and take two pieces, one on the dorsal strut and one on the caudal strut, caudal or columnar strut. It depends on the patient requirement.
Right.
And you suture it. You can make a step. You can make a step like you can take a thick cartilage and you can make a step.
Right, I understand.
You can
a
give
V type of cut so that the dorsal strut sits on the caudal strut.
Caudal strut and dorsal strut. You can suture it.
Okay. Thank you so much, sir.
I think I answered to the question.
Yes, perfect. It is. We have Dr. Sarwat Taufik from Iraq, from Suleimania, Iraq. I've seen them doing a lot of rhinoplasties. Dr. Sarwat, you want to say something about this? I've seen you doing a lot of rhinoplasties. They have a lot of humps, you know. You want to say something?
Yeah. Can you? Yeah.
We can hear you.
Good evening, Dr. Palata.
Yeah.
Can you hear me?
Yes, sir.
Yeah. Good evening. Thank you for
Good
these
evening.
nice webinars. Actually, they are beneficial. Yes, of course, because Middle East noses are typical candidates many times for rhinoplasty, actually, as you know. So there's some specificity between noses from Indian and Caucasian noses. Crook noses are also present much more here because of old trauma, and the area is, you know, it's a mountain, so we have many crooked noses, and so many. My question is, what to the presenter was that those noses with some who are crooked and at the same time they seems to have a saddle nose. What's the best options before going to the reconstruction by rib cartilage? Is there any place for local septal cartilage to be sufficient for that, please?
You got the question, Dr. Chidanand?
Yeah, the question is, what is the best material to do the saddle nose correction?
In a patient who
Yes.
has a crooked nose deformity also,
Crooked nose
Yes.
deformity,
plus saddling.
crooked nose with saddle nose. I showed
Yeah.
one picture, like
Yeah.
it looks like crooked, but because of the, it looks saddle nose because of the deviation. So you can do extracorporeal septoplasty in such condition.
Mm-hmm.
You know, extracorporeal septoplasty, you harvest the cartilage from the entire septum, the bony part as well as the cartilaginous part.
Yeah.
You do medial osteotomy on either side, and
Yes.
do a transverse osteotomy at the end, at the renion area, and remove entire septum.
Yeah.
Entire
Yes.
septum, and you reconstruct the septum with the whatever cartilage which is available. If you don't have any septal cartilage available, you can use rib cartilage. You can use rib cartilage and harvest. You can correct it.
Yeah. Thanks, sir.
Yeah.
Okay.
Thank you for joining, Dr. Sarvat. I have noticed you have been joining regularly for our programs. So nice of you. We didn't meet each other for a long time, almost now 3 years. We should meet soon. Yeah, with the during the forthcoming
I hope.
Endosuli. I will be
Yeah.
there for Endosuli. I'm coming there. Okay. Yeah, definitely.
Sure,
I'll
we
be
are
there.
welcoming you always.
Yeah, thank you very much.
Thanks.
Yeah, thank
Thanks
you.
a lot.
Any other questions, friends? We have, though we had a small audience, I think a maximum of about 48 audience we had, but we had a diverse audience. We had participants from Middle East, from Africa, from Far East, from Indonesia, many countries. Okay, that was anyway. Thank you very much, friends, for joining us. You motivate us to do more of such programs. For us, it's not the quantity of the audience; it's the quality of the audience which is more important. You motivate us to keep doing the more such programs. We'll bring more insight into more topics in the future. More maestros who have a lot of experience in their field, who are masters in their craft, and we'll bring them. Through them, we'll learn these nitty-gritties, nuances of the various surgeries. ENT is a vast field. Chidanand, he showed that fantastic slide, the different ways, different opportunities available in otorhinolaryngology. So we will bring each and every surgery here on this platform. Dr. Chidanand, thank you very much for sharing your valuable time on a Sunday evening.
Yes, sir.
I know that was supposed to be dedicated to your families, but you shared that valuable time with us. Most important, you shared your philosophy, the secrets you're using. I mean, that is what is important. That marks a great teacher, not just as a great surgeon, great master. You have had a phenomenal growth. I want to see you still at a very high pedestal. All the best for your future endeavor, Dr. Chidanand. Thank you very much. Thank you very much, friends. Have a happy weekend, happy, healthy, safe weekend, and look forward to have you again next weekend with our more exciting programs. So that is Jana Club and Weekend with the Maestro. Thank you very much. Really honored to have all of you here. Thank you.
Thank you.